analytic methods in the study of risk factors for and consequences of endometriosis. What she's going to talk about this morning is adolescent endometriosis. What we do now matters later. Professor Missmer.
Good morning, and thank you, of course, to our gracious hosts, Dr. Sechkin and Ms. Lakshmi, and also as being in the cleanup position for this first panel of the morning. I'm going to present somewhat of a summary of what my esteemed colleagues have already discussed, but also try to put in a context of what we need to be doing now as both scientists and as people who care about women and girls with endometriosis to move the field forward. So we're still charged with the question of what really is endometriosis? And it's been 15 years ago that there were another group of studies that suggested descriptions across typical symptoms and typical experiences of women with endometriosis. In 1996, there was the US Interview Survey, where women with endometriosis reported that on average they experienced 18 bed days per year. And within this study, bed days were defined as days in which women were unable to go about their normal activities, whether at work or at home, because of the symptoms of disease. In this same year, there was also a publication from a large study based in Chicago that enrolled almost 700 patients, half of whom presented with pain symptoms, half of whom presented with infertility. And they suggested, as has been shown in other work, that the symptom presentation really does differ, with 80% of those presenting with pain showing moderate to severe pain that, again, hits that bed day level of impairing quality of life and daily activities, while 15% of the infertile group reported this moderate to severe pain symptoms. There were differences in diagnosis timing. The delay was much greater in women who presented with pain. They were diagnosed at a later stage, and there were different patient characteristics. So, for example, a critical thing to take on board when we're thinking specifically about adolescents with endometriosis is that virtually all of these patients are presenting solely with pain. And we often conflate research and clinical attention regarding infertile populations versus those who are presenting with pain symptoms. In a study that we conducted and has been also duplicated by some others, when we look at potential risk factors or etiologic factors with endometriosis, if we separate the patients by presentation of pain or infertility, we do see some differential associations. Here's just one example where cigarette smoking history and current smoking levels, we saw an increased risk with endometriosis diagnosis in those who present with pain, but a decreased risk with infertility. This may speak to the complexity of cigarette exposures. There's a hypoestrogenic state, which should be protective for endometriosis. However, there obviously are many toxins, phytoestrogens, and other growth and immunologic related factors that are present in cigarette smoking. But the key point here is that we have to think more critically about phenotypic variation in both symptoms and appearance of disease. So going back to the key question that we're all charged with is, what is endometriosis? What does variation in lesion appearance mean? Is the different appearance that's typical of adolescents versus women diagnosed in their late 20s and into their 30s actually indicative of earlier stage disease that will then progress had we visualize that woman at 30 instead of at 15? Or does it indicate a distinct disease pathology, a distinct disease pathway that needs to be considered more critically? What also, as has been mentioned earlier this morning, what is the significance of superficial peritoneal endometriosis versus deep infiltrating endometriosis versus endometrioma when we're thinking in respect of genetic, epigenetic, risk factor, and other pathophysiologically important pathways? What is the difference between women and among different age groups for the propensity for scarring and adhesions? What is the fertility risks that are inherent in girls who are diagnosed in their adolescence? We, as also already Dr. Dugas has summarized, we don't really know. We have to be very careful about a conflation of endometriosis with infertility. The majority of women with endometriosis are fertile and go on to have spontaneous conceptions. And so we need to think critically when we're making these distinctions about symptom presentation and phenotypic appearance. What are pain symptom patterns? As has already also been described, there is very little data looking at the natural progression and the variation in pain symptoms over time given different treatments and in the absence of treatment. And also, what are the multisystemic variation in inflammatory and immune responses, rheumatologic diseases, gastroenterologic diseases? There is some data looking at dermatologic factors and endometriosis. And all of these very distinct, currently observed variation needs to be addressed in what we're doing in terms of data collection and sample stratification and interpretation of the results and our conclusions for the field. We know that the current classification system, which is most broadly used, doesn't correlate well with symptoms, and it's questionable depending on what circumstances we're looking at for outcomes. And so a key challenge to the field is working on, again, broadening this phenotypic definition and really looking at these nuanced variations of disease presentation. As already has been mentioned, there have been no case control cohort or randomized control trials specifically within adolescents. The questions remain, again, are there risk factor differences that are specific to the population of girls who during adolescence are experiencing severe pelvic pain and are receiving a laparoscopic visualization and treatment? What are the critical windows of exposure timing? Do they differ for patients who are presenting with symptoms at these earlier ages versus women who are experiencing later evidence of pain symptoms and of infertility? Is there a phenotypic specific treatment that's critical to develop for endometriosis? There likely is. There is this degree of variation, as we again have already heard. There are 50 to 60% recurrent rates, particularly for pain. We do much better for the treatment of infertility. But what could these nuances of phenotypic presentation and nuances in treatment response tell us about honing in patient-specific treatments? What is the reproductive prognosis, and what is the ultimate comorbidity risk? What are the risks overall of developing autoimmune diseases? What are the risks of developing cancer, which I'll talk about in a moment, and other chronic conditions associated with endometriosis? Are the risks greater in girls who are presenting with symptoms versus women who are experiencing infertility or other presentation patterns? Thinking specifically about different designs, one of the most rigorous designs, of course, is randomized controlled trials. There have not been randomized controlled trials in adolescents. And of course, the advantage of a trial is that we are assigning the exposures, and so we are randomizing across all of that human variation that we quantify poorly and differences between people that may be influencing what the outcomes are. Also, we can determine the exact temporality of these exposures and the outcomes. However, there are important limitations for randomized trials in our current understanding of adolescent endometriosis. They really are an invalid method for discovery. You have to know what you're trying to randomize and the expected outcomes and effects before we can choose randomized designs. We can't ever evaluate harmful exposures with randomized controlled trials. We can't evaluate personal patient characteristics such as body size, age at menarche, characteristics like that cannot be affected by the scientist. And we can't evaluate the impact of varying exposure timing. Once we commit to a trial, we are presenting that exposure to the enrolled population at this specific point in time. If the critical window were when they were children or early adolescents, then that window is already missed if we're enrolling women who are now in their 30s. We have to choose a specific level of exposure, which again goes back to the discovery issue. We really need to understand what the critical elements are before we define how we will handle this trial. And I have these highlighted because depending on the population we choose, randomized controlled trials have to be considered critically for generalizability. There can be compliance issues, and typically they're of shorter duration. All of these are surpassable and typical within the field of trials, but something critical to think about, particularly when we're involving adolescents and thinking over a long period of time. We also have to consider that a randomized controlled trial really is a prospective cohort study where we're assigning the exposure. And so the majority of the literature on trials in endometriosis is in pharmaceutical treatments, but also specific to surgical intervention within infertile populations prior to assisted reproductive therapy. And so those trials have been very successful in design in that, particularly for pregnancy outcomes, there's a short duration, there's a very specific treatment. But now we're attempting to utilize those populations to look over time and say, okay, we have this population of women who had surgical treatment, a population of women who did not. Now, 2, 3, 5 years later, what is their pain profile? What are the other symptom profiles? How many have come back for repeat treatment? And the critical thing for those designs is to consider that now this is no longer in the realm strictly of a randomized trial. Now we're looking at additional outcomes, and so it takes on the nature of a prospective cohort. And we have to be collecting, as Dr. Duga has also said, we have to be collecting over time information about pregnancy changes, treatment, hormonal treatment changes, other lifestyle factor changes over that time period that may also be affecting disease recurrence, repeat surgery, and pain symptoms. Speaking of prospective cohorts, much of my research is based in the 2 prospective cohorts of the Nurses' Health Study, where we have enrolled almost 120,000 female nurses and have been following them for about 20 years. But this is a population that's not been advantageous for us for thinking about adolescent endometriosis. All of these women were at age 25 or older. They were also enrolled in 1989, and so the time period during which they were children and adolescents really preceded modern understanding and modern techniques related to endometriosis. We have now enrolled 15,000 of their daughters, and so we have multi-generational data. They were 9 to 14 years at enrollment, and so we've had the ability to have a much more critical eye with respect to endometriosis. We're starting to build, they're getting into their early 20s, and so to date we've had 250 incident surgically confirmed endometriosis cases reported. But again, reviewing some of what's been said earlier today, among these girls and now young women, 3,000 have reported moderate to severe dysmenorrhea. Again, moderate to severe being defined as influencing their quality of life and daily activity. And so really thinking more broadly about pelvic pain and what thresholds are critical to consider in terms of what is normal or typical pain versus atypical pain indicative of critical pathology is very important. However, there are many international prospective cohorts primarily designed to look at cancer and cardiovascular disease outcomes. It's a critical opportunity for our community to utilize these data and think about some life course information for endometriosis. But the critical concern is that few of these cohorts, almost none, have collected information on endometriosis retrospectively or prospectively. And so a case in point is 3 weeks ago there was the publication in Lancet Oncology from the American Cancer Association Consortium on endometriosis and ovarian cancer risk. There were 13 studies. They were all case control studies designed to look specifically at ovarian cancer with 8,000 ovarian cancer cases and 13,000 controls. This study reported that women with endometriosis had a 3-fold risk of clear cell ovarian cancer and a 2-fold risk of endometrioid or low-grade serous ovarian cancer. And they focused a great deal on the subtype differences. However, there's been a lot of media attention to this research, and one critical issue that's a bit beyond our purposes today is that it's been lost somewhat that there are very small absolute risks nonetheless within this group. And so, women with endometriosis, if there is a true association, this is not a huge population level cancer issue. But thinking about our design and our contribution as the endometriosis scientific and clinical community is that all of this study, like most of the large cohorts, did not collect any endometriosis information other than to include on a questionnaire to their participants, have you ever been diagnosed with endometriosis? And we know that from that self-report with no qualification and no medical record evaluation, that self-report is actually very poor for endometriosis, and it's poor in a complex way. There are just a few examples. There was a Midwestern United States study of polychlorinated biphenyls, and they had self-reported endometriosis. When they went back to the medical records, only 47% of those who said, yes, I have endometriosis, actually had a medical confirmation. In the Black Women's Health Study cohort, which is a population of women who self-identify as being of African American ancestry in the United States, they reported having endometriosis, and in that population, only 52% could be confirmed within the medical records. Even within our Nurses' Health Study cohort, when we evaluate the women who did not also, in addition to saying, yes, a physician told me that I have endometriosis, if they did not also have a surgical confirmation, the confirmation rate was again around this 50%, 54%. You really have to get to the level of having the documented surgical confirmation to reach accurate levels. And the critical concern in terms of scientific and clinical interpretation is that in these 50% or so who were wrong about their self-report of endometriosis, it's not that it's just completely misclassified and erroneous. They're typically reports of conflation of other gynecologic pathology or testing and treatments. They report endometriosis instead of adenomyosis, endometritis, endometrial polyps, having had an endometrial biopsy, all of these gynecologic terms that are similar to but not specific to endometriosis. And so that actually biases in a different direction from what we would expect if it was just wrong. It may bias because of a conflation of all these other pathologic factors that are now being summarized across to look at these associations. So we as a field have to critically demand valid case definitions. We have to be very specific about what we mean and also think through these nuances of phenotypic subtypes. We also need to prioritize investigation of establishment of less invasive methods, and many groups are working on that at this time, and there will be more discussion of that later today. We also, when we think about these cancer or other chronic disease associations, we really need to challenge the thought of a causal relationship with endometriosis. If this is a true association, then there really are three possible pathways for this relationship. It is possible that endometriosis has some causal function in the future development of ovarian cancer. There have also been reports of associations with breast cancer, lymphomas, melanoma, and it is biologically possible that there is some causal relation that we need to investigate further to determine. It's also possible that there's something related to the, in particular, long-term hormonal and immunologic treatments for endometriosis that could be influencing risk. So it's not the disease state itself, but rather the necessary disease symptom interventions. What's the most probable pathway, however, is that there likely are common risk factors, common hormonal, immunologic, other aberrant milieus that are impacting both the risk of endometriosis and separately in a multisystemic factor, the risk for these other outcomes. All of these pathways are discernible and need the multidisciplinary attention of our bench scientists, our epidemiologists, our clinical researchers to tease this apart. But whenever we see associations like this, we have to think very critically about what the implications are and what that means for our next steps in the field. And again, there is value in knowing if women with endometriosis are at high risk for other chronic diseases, including cancers. It can affect screening patterns for those cancers that have solid screening information. It can also affect, again, life-term monitoring and interaction with the healthcare field. But we need to be very careful about our interpretations. There also have not been case control studies. Again, a critical issue about case control studies is this case definition and thinking about stratifying across presentation by pain or infertility, what the differential lesion appearance is, presence of adhesion and scarring. We also have to think critically about the control selection. So do we compare women with infertility to women who are fertile? Do we compare women with pain symptoms for endometriosis to those with infertility presentation? Do we compare those with stage 1 and stage 2 disease to those with stage 3 and 4 disease? And when is it appropriate to use a general population sample? One nice thing about the very large prospective cohorts is that we can be certain that there are women within those cohorts who have not been diagnosed with endometriosis who have existing disease. But in a sample of 120,000 women, if we have 10,000 confirmed endometriosis cases, then the characteristics of those not yet diagnosed women gets diluted within the other 90 to 100,000 women. This is much more critical to consider when we're thinking in terms of smaller case control studies. And really, the choice of control group has to be driven by the hypothesis that you're addressing. If we're trying to discover diagnostics, then comparing a group of women who present with symptoms and may or may not have endometriosis, so comparing those who are determined to have endometriosis to those who have other pathology is very, very important, because that's the diagnostic distinction. If we're looking for etiologic factors, however, comparing women with endometriosis to women with uterine fibroids, for example, may conflate relationships when there are similar hormonal or immunologic milieu at work. We also need to think critically about the exposure window, and I'll talk about that in a little bit, which is very important when we think of endometriosis in adolescents and what timing may be occurring in terms of establishing the disease, and then also sample size. So an example of control selection is in the study of persistent organochlorines. This was one of the most addressed associations, particularly in the 80s and into the 90s. There have been 13 case control studies. They largely have had inconsistent results. But within these 13 studies, there were 7 very distinct control definitions. And so comparability and interpretation is really impaired. Also within this particular field for the persistent organochlorines, the range of sample sizes in these studies went from 10 at the smallest to 96 at the largest, all of which were underpowered for looking at these specific associations. Even the largest studies would need to see a 2- to 4-fold risk with an individual persistent organochlorine, and that's a magnitude of effect that's not typical for the field. And so there may be true relations here that we just have not yet sufficiently uncovered because of this variation in study design and critically the sample size issues. With regard to exposure timing, Teresa Woodruff and Linda Giudice had published this schematic thinking of these critical windows of development in utero, as an infant, and during adolescence. And when we think about adolescent endometriosis, if we're trying to determine risk factors that are pathophysiologically informative for treatment development and also informative for potential prevention and influence on the disease, we really need to be thinking in terms of early life exposures. So we and others have observed an association between diethylstilbestrol exposure and endometriosis risk, with about an 80% increased risk in the women who were exposed in utero. We have also observed, and has been confirmed within some French groups and also Sue Traylor's Australian research, that those women and girls who they themselves had a lower birth weight were at higher risk of endometriosis diagnosis versus those who were born with a higher birth weight. And interesting with respect to body size, which has been one of the most consistent epidemiologic findings, is that this relationship persists across the life course and particularly strong in childhood and adolescence, with again the same pattern of thinner girls, this is an average of ages 5 and 10 body size, being associated with higher risk compared to the heavier girls who had lower risk of diagnosis. This also persists to age 18 and into adulthood. And so again, thinking of these critical windows, perhaps even pre-thelarchal windows of exposure and what these patterns may suggest for pathophysiology of the disease. Very consistent in literature, has also been mentioned today, is this relationship of a later age at menarche being associated with lower risk. Thinking through all the genetic and epigenetic and hormonal factors related to age at menarche, teasing out the details of what may be happening in these very early in utero and childhood exposures is critical for the field. We've also been looking at adult diet and endometriosis. So in women within the Nurses' Health Study, those who were consuming higher amounts of omega-3 fatty acids, the healthier fatty acids, had a lower risk of being diagnosed with endometriosis. We have to think critically in terms of these diet factors because these are associations with diagnosis. And so if the diet is influencing pain symptoms or fertility, it may not be a true association with the disease itself, but rather presentation for surgical confirmation. Similarly, we saw an increased risk with unhealthy or trans fats consumption. This data has been confirmed also within Kevin Osteen and Kaylin Bruner-Tran's work within their rat models. They seem very similar association. We also see a protective effect of vitamin A, which is also work that Rob Taylor's group is working on. However, when we separate out the components of vitamin A, we don't see a relationship with retinol itself, but rather with the pro-vitamin A carotenoids, beta-carotene and alpha-carotene. And the critical information for our purposes, thinking about adolescents, is that for several primarily hormonally based diseases, such as breast cancer, also some evidence with colon cancer, there have been associations with menstrual characteristics and polycystic ovarian syndrome and some other outcomes. What we've observed in the adult diet is actually more strongly associated when we evaluate adolescent diets. And so again, thinking through windows of exposure and critical associations and potential alteration of disease within those different life course issues is critical. So what's important for us to do now? We need to establish standard surgical and pathologic case reporting details that can be used across all clinics and groups. One difficulty for studies where their medical record abstraction is important is that there's such variation in the details of the phenotype of the disease that are being reported, and so we're very limited in that respect. Establishing standard minimum baseline and longitudinal data collection tools, again, that was referred to earlier, the critical importance of creating standard questionnaires that are used internationally so that these data can be combined and considered critically. We also need to form multidisciplinary teams. The focus of research and the expertise of just the panel this morning is very varied and comes at these questions from very different approaches. Our keynote speakers later today and the rest of today will also highlight that importance. And so forming these multidisciplinary teams, attacking these questions from many different angles is absolutely critical. And joining collaborative groups, sample size, sample size, sample size. We need to be increasing the variation of girls and women that we're looking at, and also just powering our studies appropriately to be able to detect these differences. We have to be thinking really paradigm-challenging thoughts. What really is endometriosis, and what do we know for sure, and what is dogma that has very thin evidence behind it? And then again, collecting data across the life course. What we need to do now among children and adolescents is collect that critical information so that we will have it to look at their fertility outcomes later, their pain patterns later, their response to treatment across the next 10, 15, and 20 years. So among clinicians, there's a similar list, although we certainly need to be educating other specialists. We need to be collaborating with and having detailed discussions with rheumatologists and gastroenterologists and nutritionists and pain management specialists, thinking about not only appropriate varied interventions, but also what types of data we can be collecting to move forward the field across this very multisystemically impacting disease. Again, multidisciplinary teams and joining collaborative groups, and questioning what we really do know about the treatment responses, questioning what in the presence of surgical intervention, what it means that there's still a 50% return to surgery rate, which is probably an underestimation of the return of pain symptoms. That's only the section of patients who come back for another invasive surgery. And again, thinking paradigm-challenging thoughts and engaging patients across the life course, following up and forming methods for keeping in contact with patients in terms of this life course outcomes for this very chronic disease, collecting data. And then everyone who cares about daughters, sisters, friends with endometriosis and pelvic pain. We have to believe that pelvic pain is meaningful. Much of the delayed diagnosis is a requirement of surpassing a certain threshold of pain to be taken seriously in terms of true underlying pathology. Continuing to bear witness has happened yesterday and is continuing to happen within this community in terms of what the experiences of endometriosis are, and really helping the clinicians and scientists to focus on the critical issues. Promoting and being very vocal about healthcare professionals who are excellent supporters and excellent clinicians and scientists within the endometriosis field. Demanding subspecialty care, again, thinking across gastroenterology and rheumatology and pain management and the other complexities of the disease. And it's very critical, particularly in adolescents, to be willing to enroll in research studies and contribute information to questionnaires and biorepositories and tissue banks, and to be able to more broadly capture the details of this disease. And so in summary of hopefully the morning's panel, we need large and collaborative, geographically diverse studies. We need to focus on this critical stratified case definition that the current staging system has not achieved. We have to think about control selection and appropriate comparison groups, and exposure data collection and covariate information from across these critical windows of development and across the life course. Thank you.